Okay, so the first thing that we want to start off talking about is what we have learned as the Bridge organization. So the first thing we learned is the value of showing up. So one thing that we wanted to do during the piloting phase is we wanted to go out to the clinics and help test and roll out those clinical workflows. And we learned, the value of actually being out in our clinics. So more than emails and more than phone calls, those in-person interactions were vital, truly fostering collaboration and ensuring that you guys know that we want to ensure your success, and we want to make sure that you guys have all the resources that you need. And even through implementation, we're continuing to visit clinics and help refine clinical workflows, and make sure that you all have, again, the resources that you need, and make sure if there's anything that we can do on our side, that we're doing that. Something else we're learning is in Eastern Kentucky, we actually went on a ride-along with LKLP, Community Action Council. Our friends over at Community Action Kentucky helped facilitate this. A few of our staff members actually went on that ride-along as they provided transportation services to Medicare beneficiaries. And we learned just how difficult it can be to get around in Eastern Kentucky. Overall, patients' awareness of medical transportation is pretty high, and most of the patients that we encountered were there for medical transport, either for diabetes or substance abuse treatment. As far as public transportation, those tend to receive lower priority as a policy. And we just, anecdotally, we saw just how difficult it can be to actually get around those roads in Eastern Kentucky, both as a distance and road conditions, how difficult it can be for those buses to get in and around and pick people up for their appointments. Something else that we've rolled out is something we're really proud of, which is CARE KY. A lot of you may already know about it, but it is the Community Asset Registry for the Empowerment of Kentucky. It is our website. It is also now a live app, both in the Apple Store and the Google Play Store. We now have over 1,000 community resources across the 27 counties taking part in our project. The app and the website is free. There's no cost to use the site or download the app. Also, something that we purposely engineered the app to do is to not require a data connection after you download the app. So if you download it when you're, say, in a Wi-Fi spot, and then you go home to an area that doesn't have internet connection, you can actually still access all those resources and still get all the information that you normally would, as it does not require a data connection any further. It is crowdsourced, so users can let us know if any programs are missing or incorrect. There are links on that website that let us know. You can input information, if a phone number is wrong, or if hours of operation are wrong, or if something's closed, or if a new program has popped up, you can let us know. As it is constantly updated, once you submit a resource to us, they are vetted by our staff, and it's regularly and continuously verified, and the new resources are immediately added to the site once they've been vetted. So the website is care-ky.org, or you can search the Google Play Store or the Apple App Store for CARE KY. So how are we doing? So far, enrollment has been slow, but we are on an upward trend week over week. We understand that there are always going to be some bumps in the very beginning. There are going to be some, hurdles to overcome at first. And some reasons we think we're falling behind a little bit are the fact that not all clinic locations were ready to implement on August 1st. A lot of people needed to hire new staff members. Some clinics joined later in the game than others, so there was a learning hurdle to overcome. Some clinics implemented a paper-based screening approach, which requires a few extra steps and can delay data entry. Some people are using paper, which just involves some scanning and uploading it to a UK server so that then we can verify the information and then enter it in on the data system. A lot of our clinics are rolling out to multiple locations. So we've started off basically at one location for all of our sites, and then some sites are expanding to other locations if they have them in counties that are taking part in the project, which is going to take a little more manpower and a lot more learning experiences and training. And again, like I said, a lot of places are onboarding new staff members, so that's always going to take some time to get one person up at each clinic who is educated in the process of the project, and then to train other people as well. So something else we'd like to do is have you guys kind of chat with each other, and we want to learn how you guys can learn from one another. This is all going to be a learning experience for all of us, so we'd like to know what works for you guys. And one clinic that actually we have realized works really well is Big Sandy. So I have invited Miss Stephanie Clark from Big Sandy to come out or to come out virtually and chat about what works for them, and maybe start some conversations about how we can all get up and running at our clinics. Stephanie, I believe you're unmuted.
Hello, can you hear me okay?
Just fine.
Okay, so my name is Stephanie Clark, and I'm the Assistant Director here at Big Sandy Healthcare. First, I want to thank you for having us participate in this project. So far, it has been quite rewarding for some of our people that's working hands-on with the patients. So some strategies of what our process is so far. Over all 5 clinics, we're trying to keep the same process across the board so everybody is on the same page. When the patient signs in at the clinic, we're having the front office administer the screening tool to the patient. And at that time, if the patient shows any indication of not being able to read the questions or maybe visually impaired, then we're asking that our front office staff either pull the patient to the side to administer the tool, or possibly after the patient has been called back for nursing to have a different staff member read the questions to the patient. And we're doing paper-based and computer. We found it a little bit faster for us to go ahead and send the packets out upon check-in, and then have the care navigator to use the computer to enter the information if needed.
And that's actually something that we found a lot of clinics are doing, is they're using what we're kind of terming as a hybrid approach, where they are handing out the paper-based screening forms and then having a separate staff member enter them into the data system, which is it's really interesting. We didn't plan ahead for that actually to be an option, so it was great to see clinics kind of taking up the process and making it their own, and then handing the screening tool to the patient, which is in a paper-based format. It's a lot easier for the patient to handle. They can sit with it in the waiting room if they want to, and then entering it in straight into the data system also allows the data system to score it for you so that you can then generate the community referral summaries really quickly. So that was something we were kind of trying to relay to a lot of the clinics, is that this hybrid approach has really proved efficient for a lot of our locations.
Yes, and it hasn't really slowed down any of our clinical flow. Basically, if the patient is in the room and waiting to be seen, they have some time in between, after the nurse is done with them and before the doctor comes in. So at that point, if our people are ready to go, then they go in that room and talk to that patient. And normally, what we have seen that's been beneficial for our clinics is 1 to 2 days a week, we have a particular staff member who is solely responsible for these screening tools. And that may be a community health worker. It may be one of our assisters that's at the clinic that day. But overall, if they're there doing the screenings, they're there to navigate, and that's their only duty for that particular day.
That's interesting. I really like that idea of having one person a few days a week just take the project on as their responsibility. I'm going to go ahead and unmute everybody in case you have any questions.
Or Stephanie?
No, what you need to do is get your cappuccino on top of it.
Anybody have any questions right now that maybe they want to ask Stephanie, or things you want to talk about as far as like a staff workflow, maybe comparing it to what's working over at Big Sandy?
Well, you need to do the coffee though, and then do that on top of it. Mix it.
Any problems you guys have encountered? I know you said it wasn't really slowing down clinical workflow, but have patients had any troubles with it, or any providers, or anything like that?
Hurt a little bit, but
We've not really encountered any kind of problems. I think the only thing that we have seen thus far is one county. We have a lot of patients coming from Johnson County, and we don't have that, or I guess we're not including that county in this navigation service. So when we have those particular patients, we just give them the best resources that we have. And then if more help is needed, we also have Lydia Phipps. I think she's on the call too. But we can have patients referred to her, and she manages the chronic care program with the community health workers. So if it's something that this program was not going to navigate the patient or work for this particular patient, then she can take over and provide further help to that particular patient.
Yeah, that's fantastic. We were worried that we were going to, in the process of excluding patients, we were going to maybe hinder their access to resources, or maybe, just not be able to help them. So that's great that you're able to work hand in hand with other staff members and be sure that the patient does get access to the resources or, some form of help. All right, that was great. Anything else? Any other questions? Or Stephanie, do you have anything else to add in about how Big Sandy's doing?
Well, one thing is, I don't know how everybody is, their process, if they're just passing them out upon check-in, but one of our clinics, after I talked to everybody at our clinics, had a really good process that I liked, and I wanted to share with you guys, is our Martin County Clinic. They have a process to where the office manager will print out a list of patients like the day before they're scheduled to be there. She'll go through those patients to determine who meets the qualifications to actually receive the screening tool. And then she writes the patient's name on that cover sheet and stacks them up in order of their appointment time. So when she's finished, she hands that stack to the check-in person. And as we all know, check-in becomes extremely busy and they get bombarded quite often. So as they're busy, they just have to glance down and take a look and see if their next patient is on their list. So it's really quick process for them to know this patient gets the tool and then give it to them and go on.
It's fantastic being able to scrub charts ahead of time. Does anybody else foresee that perhaps being an option to kind of ease the friction of, checking in a lot of patients during the day or anything like that? Well, we will definitely document that as a feasible workflow, and I'm sure as the quarters go on, a lot of clinics will reshape their workflows, figure out what works better for them, and we'll keep that in mind going through. Well, Stephanie, thank you so much for agreeing to chat a little bit and let us know how Big Sandy's doing and give us all some great ideas. We really appreciate it.
You're welcome. Thank you.
All right, so moving forward, we have found some areas for improvement. Mainly, one of the first things that we see is screening outside of the geographical target area. So if you look at the map, you can see the counties marked in blue are ones that are included in the project as one of those 27 counties. To be eligible to fill out the screening form, a patient has to live in one of those blue counties. Now, if a patient does not meet that guideline, but you suspect that they may have health-related social needs, you can provide them with what's called a mini CRI, that's what we're calling it, that lists some common resources in the counties that border those listed on the cover sheet. So the counties that we have a mini CRI for are marked in orange there. Now, if you find that a lot of patients are coming in with HRSNs from a county that is not marked in orange, go ahead and let us know, and we'll see what we can do about compiling some resources that you can give to the patient. So essentially, they're not leaving the clinic empty-handed. And screening tools that are filled out by the patients outside of the GTA will not be entered into the data system and will therefore not count towards your clinic's target enrollment goals. So if you find that maybe 1 week, if your enrollment numbers are lower than you had anticipated, maybe some of those screening tools did come from clinics that are not highlighted in blue here. So we'll work to make sure that you guys are accurately kind of screening patients that are really targeted for the project. So something else that we can improve on is making sure that we're following up within the 48 hours to begin navigation. Any patient that is eligible for navigation, so remember that means that they have 1 core HRSN and 2 or more ED visits in the last 12 months, they need to be followed up within 48 hours with a personal interview or action plan. Now, we know that was going to be one of the most difficult things to accomplish with the project, with transportation being such a difficult health-related social need, and just the general staff workflow. We knew it was probably going to have to happen within the same clinic visit. But in order to kind of shorten the amount of time that was devoted to the personal interview and action plan, we made an abbreviated form for clinics that are unable to devote much time to the interaction. Let us know if you want this new form. We can go ahead and send it out to everybody. It still captures all the information that's needed as far as documenting their HRSNs, getting some goals for the patient, some barriers, and some actionable items. But it's just in a much briefer version, so it only takes about 5 minutes, so you can get those patients in and out without slowing things down too much. We are seeing that about 40% of patients eligible for navigation are not being offered services, and half of those that are offered services had no activity on their chart. So personal interview or action plan had not taken place. This kind of borders on an ethical issue where we are identifying patients that are eligible for a resource, and that resource being navigation, but they're not being followed up with, and they're not actually receiving that resource that we've realized that they are eligible for. So let's be sure that we're keeping a close eye on those navigation charts. If you are working straight into the data system, the system will automatically open up a navigation case for the patient. So once you finish that screening tool, there will be a blue button that pops up that says Begin Navigation. Just be sure you initiate that within the first 48 hours. We'll do our best to make sure that we're following up with clinics that are missing that window, and just be sure to let us know if there's anything, any resources you guys need to make sure that that happens within those first 2 days. And the next thing for improvement, required information for scanned forms. For the clinics that are scanning forms and sending them into us, we want to make sure that we are entering your data as completely as possible. We want to make sure that we have demographic information on the front of the screening tool. That needs to include the patient's first and last name, their Medicare or Medicaid number, their date of birth, and their address. This is imperative for us to even open up a case in the data system. Without that information, we cannot enter in the screening tool. So if, for example, we find a chart that does not have that information, we then have to set it aside and contact the clinic and wait for you guys to follow up with us. Screening tools missing this information, it will cause a delay in data entry. So you can see just the sheets that need to be scanned back to us. Obviously, a cover page needs to go in the very front, followed by the screening tools. If you are just sending us navigation forms, either that interview and action plan or the follow-up navigation encounter, you do not need to send us the screen or the cover page, because it does have basic demographic information up at the top there, and we can go ahead and look up the patient's information using that. Okay, so I'm going to go ahead and open up the mic again. Feel free to share any of your thoughts, or if you have questions on anything, I'll open up the mics right now. It is unmuted. If you have anything to say, go ahead.
And hi, this is Mark Williams. I just want to thank everyone. We're really thrilled with all the progress we've made so far, and really phenomenal participation on this call. There's nearly 40 people working with us just on this call, and so we're going to continue to contact us. I know it's sometimes hard to talk with a large group like this, even on a conference call, so don't hesitate to email Amanda or Rich or Chris or anybody on our team, or even me, if you have any questions and how we may be able to help you do this. We're thrilled to see the successes we are having in a lot of the clinics, and are really working to figure out how can we have this occur everywhere. So again, thanks so much for all your work on this. I really believe firmly it's helping the citizens in Eastern Kentucky a lot.
All right, anything else? Does anybody have, we'll move on to if anybody has success stories. If anybody has a patient that the project really helped getting patients in contact with those resources, if anybody has just kind of a bright star moment, or if there are any specific challenges that your clinic is facing, we'd love to hear about it.
This is Melinda with Big Sandy Healthcare. I had a patient who had came in. They were homeless, and I was able to talk to them. I was able to get them housing. I actually was able to hook them up with a job. I talked to our community health worker, and she was able to get them food, and we took them and got them clothing and everything, and it was very rewarding. It worked out very well. I've also had patients that maybe they didn't feel comfortable talking to their provider whenever they felt lonely or they felt depressed or something. And, you know, I frequently have a couple of clients who just call me once or twice a week just to talk because they don't have anybody to talk to. So I feel like it's done a good service to our patients. You know, some of the people that you think has it completely together, some of the patients that, you know, are hurting the worst. So it's good to have that one-on-one time with them and get to talk to them and, you know, do whatever we can to help them.
Thank you so much for sharing that. That's almost a pretty much perfect embodiment of what we're trying to accomplish with this project. If you're still on the line, I remember you had a great example of a patient really being appreciative and kind of seeing the overall impact of the project. Would you care to share that?
Yeah, she was very grateful. You know, I've had her come in and talk with me and volunteer and ask if there's anything that she could do. She actually got involved with one of our local churches that offer services to people in need. You know, she sat and told me how much she appreciates us, and you know, we've had them come in and just, you know, see it and tell us that, they've prayed for us, and they're very thankful that, that we've been able to help them. And then sometimes I have some that just sit there and cry, and, they're like, will you pray for me and tell me their situation? And it's very rewarding. It's hard not to get attached to some of the people and take it, personal. But I think it's done awesome. We've had a lot of people, appreciate it and tell us how much that they're very thankful that we helped them, and they've been referring other people to us. So it's been very rewarding.
Awesome. We really love to hear that. Thanks so much for sharing. Okay, so we'll go ahead and move on. So we want to talk about what's next and how we can close out quarter two, this quarter that we're finishing out is quarter two, and how we can prepare for quarter three. So finishing up quarter two, that'll be August of this year through October of this year. Now that we've had time to kind of settle into a good clinic workflow, it's time for us to really, double down and get those enrollment numbers up. As I kind of distributed to a bunch of, or it should have been to all the clinics, we will be monitoring enrollment targets from each clinic. Reports are sent out with two clinic managers once a week. And beginning on October 1st, if your clinic falls below 75% of target enrollment for 2 consecutive weeks, we're going to go ahead and schedule a conference call with UK staff in your clinic just to discuss possible barriers and solutions. A lot of times, low enrollment numbers are due to a simple either, someone being on vacation, or your clinic had another obligation to, say, go to another training in another city or something like that. So we definitely want to hear from you guys and figure out why your enrollment numbers may be a little low. And if your clinic falls below 50% of target enrollment for 2 consecutive weeks, we're going to go ahead and schedule an in-person visit so that we can not only hear from you guys, but again, show up and we can maybe help with a workflow and help formulate just maybe a different feasible plan that may work for you guys. And looking forward to quarter three, there may be challenges during this period, the largest of which will be holidays and open enrollment. And we want to hear from you guys if you know that, say, the holidays, maybe the entire month of December is slow for you all, or if you know that open enrollment will really slow down your numbers. I'm going to go ahead and unmute everybody again, and we want to hear from you all. Wants to chat about, it looks like open enrollment this year falls in early November. Do you all foresee that definitely taking priority over the project? Do you see it maybe being able to take place at the same time, or is it going to take one of your staff members out of commission? Around the Christmas holidays, do you think that will maybe slow down your enrollment numbers as far as, taking one of your, or more than one of your staff members completely out of commission? Anything we can look forward to ahead of time? Okay, well, we'll move on from here. So that's all I have for today. We definitely appreciate you all hopping on the phone or, hopping on the webinar. This is something that we want to do at least once every 6 months. We may even do it once every quarter. It's a great time for you all to, hear from us and for us to hear from you, and definitely for you all to collaborate with one another. We want to definitely know that you all are supported throughout the project and have opportunities to learn from one another. As always, if you ever need anything, feel free to email myself. Most of you already have a cell phone number for me. You can call or text that number. If you don't, it is in my email signature, and let me know if you don't have it. I'll send that over to you all. Rich Herndon is also our project manager. Feel free to reach out to him if you need anything else. Later on today, I'll see if I can push out this recording for anybody else that didn't make it. And yeah, that's pretty much it. Does anybody else have anything they want to add? Okay, we appreciate you all. Have a good rest of your day.